In terms of accreditation, this program is a 1 credit per hour group learning program that meets the certification criteria of the College of Family Physicians of Canada and has been certified by Queen's University for up to 1.5 Mainpro Plus credits. For our Royal College specialist colleagues, this event is an accredited group learning activity, Section 1, as defined by the Maintenance of Certification Program of the Royal College of Physicians and Surgeons of Canada and approved by Queen's University Office of CPD. You may claim a maximum of 1.5 hours. In terms of my disclosures, I have received stipends or honoraria from the Ontario College of Family Physicians, Humber River Health, the Canadian Journal of Urology, the Canadian Urological Association, and the pharmaceutical companies listed here in Canada. For this evening's program, this program has received financial support in the form of an educational grant from AstraZeneca. The program has received no in-kind support, and as moderator, I have no conflicts to declare. In terms of mitigating potential bias, the potential sources of bias identified in the preceding 2 slides have been mitigated as follows. Information and recommendations provided in the following program will be evidenced and/or guideline-based, and opinions of the speaker will be identified as such. The Planning Committee will review evaluations of the program and address with the speaker should any bias have been introduced as indicated by you, the participants. Tonight's program, an update in asthma and allergies 2024. And as I had indicated, we're very fortunate to have Dr. Harold Kim, who practices as an allergist in Kitchener in London, Ontario. He has appointments as associate professor at Western University and assistant clinical professor at McMaster University. He is the chief and chair of the Division of Clinical Immunology and Allergy at Western. He completed his medical degree, internal medicine and allergy training at UWO, which was the University of Western Ontario, now known as Western. He has been involved in clinical research leading to over 100 peer-reviewed publications. He has been a participant in Canadian asthma guidelines, Canadian allergen immunotherapy guidelines, and Canadian food immunotherapy guidelines. He is the chief editor of Allergy, Asthma, and Clinical Immunology, and he is the past president of the Canadian Society of Allergy and Clinical Immunology. But his primary passion in clinical immunology and allergy is patient care, followed very closely by medical education. So I'm going to turn the program over to Dr. Kim.
Thank you so much, Dr. Kushner. I'd like to thank Art for asking me to speak for the springtime allergy and asthma update. Great, thank you. And he's done an amazing job of getting this out to physicians across the country. It's unbelievable. It's amazing with what AI does, and of course Microsoft is tied into AI. And now when you put a PowerPoint slides together, it actually gives you some ideas for what would be good backgrounds. And this image of molecular structure behind the title is not something that we think about much in allergy, but the last section of this talk, I'm going to talk about a potential cure for an uncommon condition in allergy. But I think when you see potentially how simple this is, we may actually have cures for a number of issues that we deal with in medicine. And you'll see it's about a condition, hereditary angioedema, but the rationale and approach to it will be applied, I think, in many areas of medicine where we literally will be curing people. So these are my potential conflicts of interest with pharmaceutical companies below that have provided speaker honorarium or advisory board honorarium for me over the last 2 years. And AstraZeneca is sponsoring the session tonight, and I will be receiving an honorarium from Humber River Hospital for the talk tonight. The product that AstraZeneca has that I will be discussing briefly in the session is budesonide formoterol. And as Art pointed out, in terms of mitigating potential biases, I think all of the information I'll be speaking to has been published in peer-reviewed literature, and almost all of the discussion will be on indication in Canada, aside from the genetic therapy that we'll be talking about at the end. So these were the objectives I put in for the discussion tonight. So reviewing asthma guidelines, and I appreciate that all of you and us are reviewing guidelines all the time. And the guidelines I'm going to discuss are the global asthma guidelines. And there have been some subtle updates, and you'll see in a minute, even last year. Then I'm going to talk about some unmet needs in asthma. And I think in medicine generally, certainly in our specialty, allergy immunology, we tend to focus on pharmaceutical or pharmacologic therapy and immunologic therapy of disease. But I'm going to talk about a couple of lifestyle studies in asthma that are quite impressive, and not just one study, but a few studies where U.S. family physicians, I think, can have a major impact on asthma without drugs. And then I'm going to talk, I know I spoke about this last year briefly, but there's a new nasal steroid antihistamine combination therapy that is effective, and it was taken off the market because there was some backorder issues and production issues, but now it's back on, and I think it's something that you should be aware of. And then at the end, I'm going to talk about a potential cure for a rare condition, hereditary angioedema. And again, as I've mentioned, I think using a model like this, we may be able to fix many issues in medicine in terms of genetic therapy. So I broke the talk into 4 sections. One, first guidelines, then talking about some studies outside of pharmacology or even immunology, lifestyle issues that can have a major impact for our patients with asthma, and then talk about this new combination therapy and this potential cure for a rare condition in allergy immunology that we deal with. So what we've done in most of the world in terms of asthma management is we've decided to use our global experts to guide us in terms of our major approaches to asthma therapy. Now, that being said, we are working on a severe asthma guidelines in Canada for this year, and hopefully will be published toward the end of the year. But for the worldwide population and for us that are trying to come up with flow diagrams and recommendations, I think the global group has done a great job of keeping us up to date. Literally, as studies are published, they will modify their guidelines. So the main goal of all of our guidelines and the global guidelines specifically are to improve symptom control. And I think that's something that we have to deal with every day with the patient in front of us, because they may not necessarily appreciate even the importance of exacerbations in lung function or death, but they do appreciate how well they're feeling right now. So we are trying to work and control that. And I think as the fallout of the benefit of dealing with asthma control is that we've had a major impact on the harder outcomes like death and exacerbations and lung function. I think in Canada, we've been arguably maybe the world leader in asthma management, because a lot of the things that the global group are pushing are things that were identified in Canada. Inhaled steroids to start with back in the 80s with John Toogood in London, exacerbations and control with Paulo Byrne now, and some of the biologic research is led by Canadian authors. A big thing that we're trying to push is to minimize oral steroids, and a term that we'd like to come up with, or I think a term that's great is steroid stewardship. And I think that's something that we should be thinking about. I don't think I have slides, or actually I do have a talk or some slides on this, that oral steroids are linked with mortality in asthma, as well as mortality in a number of other conditions. But certainly in asthma, the more oral steroids you get, the more likely you're going to die over the next 10 to 20 years in young adults. And I'll show you the data in a minute. So what the global group has done is to try to get across that it's all of these issues in terms of assessment, adjusting therapy, and monitoring our patients that have led to improved outcomes. And in the bottom right, yes, this works here. In the bottom right, I'm going to talk about two potentially really important non-pharmacologic management issues in asthma that will improve your patient's clinical outcomes potentially. And then we'll talk a little bit about medications at the start now. And then we're going to also talk about the issue of oral steroids. So most of you have seen this. This is the major approach to managing asthma. So option one, or track one, the global group refers to, is the reliever medication should be a combination inhaled steroid formoterol, which in Canada is Symbicort. So Symbicort PRN. And then if they need it more than PRN, then you go up to low maintenance dose, higher maintenance dose, and then you consider adding a LAMA. Typically Spiriva would be the LAMA, or go to a triple therapy inhaler, and then the biologics that we have available. There's 5 biologics that we use fairly commonly now in asthma. They've had a major impact on outcomes, steroid sparing, and improved quality of life in asthma control. So this is the flow diagram 1. Flow diagram 2 is if you're not going to use the formoterol ICS combination as your reliever, you can use inhaled steroid and salbutamol as a reliever. So I'll show you the study in a minute. And I do this now routinely. So this is officially for adolescents and adults, these flow diagrams. And I'll show you the pediatric flow diagrams in a minute. But I think for all patients, we should be giving the steroid with the bronchodilator. You can use a bronchodilator alone, but in my opinion, now there's a large body of evidence that suggests that we should almost never use a salbutamol inhaler on its own as a rescue. With this flow diagram, you go with low-dose inhaled steroid plus bronchodilator as needed, slowly go up till you get the combination, and then like the diagram above, we get to the adding the LAMAs or triple therapy and biologics. So this is the adult approach. So this is flow diagram 1, where they refer to the Symbicort as an anti-inflammatory reliever, which I think is a great term. And on the bottom, the inhaled steroid SABA combination is also an anti-inflammatory reliever. What I sometimes do, especially in kids that need the aero chamber, is I'll actually have the parents cut a bigger hole in the end of the aero chamber, and they can stick the inhaled steroid and the bronchodilator together because we don't have a salbutamol combination inhaler in Canada, like in many areas of the world they do have. Then the parents can give both puffers together and deliver both drugs together at the same time. And again, very rarely do we use the bronchodilator on its own, at least in terms of my recommendations. So some of the terminology that you're familiar with, reliever, controller, maintenance therapy, are things that we want to make sure that we educate patients about. And so this is one of the main studies showing that bronchodilator alone compared to formoterol with salbutamol, or sorry, budesonide plus formoterol is better than terbutaline alone. And it's also, a study was done compared to salbutamol. And essentially, if you have them on steroid bronchodilator together, then you're going to have a major impact on exacerbations. And to be honest, when this study was first published, or studies were first thought of, many of us as asthma specialists thought that the studies were going to be negative. But 3 major studies were positive with this combination inhaler as a rescue. And then this study is a study that was published amazingly in the New England Journal of Medicine several years ago. This is actually, it's an older paper. And when we look at this, and we kind of forgot about this way back, and now looking at it again. So it was beclomethasone and salbutamol 15 years ago. And this study is now looking at salbutamol and budesonide as a rescue. And you can see that using the steroid and the bronchodilator together is better than using the bronchodilator on its own. So this is the second major PAPI study. Now, when we look at kids, things change a little bit. So again, with 6 to 12-year-olds, they recommend going with SABA or salbutamol as a bronchodilator or Bricanil as a bronchodilator, and then the combination as an option. My personal feeling is I think we have enough data that I think we should actually go with the combination as the first option, whether you go with Symbicort or whether you go with the steroid and salbutamol as a combo in Canada. And then the rest of the flow diagram is very similar. But again, upfront, I would favor the ICS bronchodilator together, personally. With kids that are younger, they recommend going with salbutamol alone as the rescue. But even in younger kids, even though we don't have great data, my personal feeling is if you really think it's asthma, is have the parents give the inhaled steroid with the bronchodilator. It's not going to hurt, and in my opinion, it probably will help many people or many kids. And the differences with the younger kids are we may be introducing leukotriene antagonists and not combination inhaler, LABAs, to young kids. So we go with basically higher doses of inhaled steroids, and we consider leukotriene antagonists added on. So it's different in the very young kids. But again, my personal feeling is go with steroid and bronchodilator together as rescue. Okay, now let's move on to some areas that I think are kind of outside of the typical areas that we speak about in asthma. The first one is this. We all have some respect for oral steroids, but I don't think we have enough respect for oral steroids in terms of the damage that they can do. So this is a large, massive population-based study from Denmark, looking at even patients that receive low doses of cumulative oral steroid, and you'll see the numbers in a minute. All of us prescribe this to many of our patients on a regular basis. May increase the mortality of patients with asthma. And it's not just with asthma. There's similar data in other areas of inflammatory disease, like the rheumatoid diseases and the bowel diseases. So oral steroids, and it may not be cause and effect in terms of mortality, but there's clearly a strong link. So what they did in this study essentially is they picked an index date with patients that were quite young, and we're talking 18 to 45 years of age. We're not expecting these people to die. And so we pick an initiation date, and they looked at these patients before the initiation date, and they had a follow-up period, and they wanted to see what the effect of death was with oral steroids. Sorry for the busy slide here, but these were the non-steroid receivers and the oral steroid receivers. And just to highlight that the groups were reasonably similar at the start. So let's look at medium dose, high dose steroids, right? 29% in each group were on medium, high dose steroids. Look at antipsychotic drugs, okay? The OCS patients and the non-OCS patients were similarly receiving those drugs. Osteoporosis, these groups were pretty similar at the start of the study, okay? And we'll see what it looks like at the end. So essentially, what they found was if we look at the hazard ratio, that's a relatively easy stat for us to appreciate. Basically, the likelihood of morbidity from these sequelae of oral steroids. So patients that had received OCS and never received OCS who had asthma, and then look at the hazard ratio. So basically, the factor that the OCS patients were at a higher risk than the non-OCS patients. So 1.4% higher likelihood of any comorbidity from OCS was the overall outcome, okay? Look at osteoporosis, 2.5 increased risk. Look at psychiatric illness, 1.4. Heart failure, 5-fold risk, right? Adrenal insufficiency, of course, makes sense. A 8.5-fold risk. So if you have patients on oral steroids, even on low doses, they are at higher risks of these significant outcomes that we see. Look at cataracts. In the nasal steroid, inhaled steroid specialties like ourselves and myself, we try to downplay some of these side effects, but these side effects occur at very high rates. So these are some of the variables in terms of morbidity. This is not mortality yet, okay? But all of these conditions in a dose-related response, so this is very convincing. The more steroid you get, the more of these sequelae you get. Even at low doses of steroid, there was a signal, a strong signal. But with high dose of steroid, look at heart failure, okay? We're talking about this kind of a dose response from low to high dose OCS. So we're talking about a major impact that is probably, in my opinion, probably related to steroids because asthma does not cause these problems on its own. So then we look at mortality. So these are all OCS receivers. You look at mortality. All-cause mortality hazard ratio was 2.2. If you're on high-dose steroid, and you'll see what high dose means in a minute, the all-cause mortality hazard ratio is 5.5. So in these young adults with asthma, if you received over 2,000 milligrams of prednisone, high dose, and that's not a lot if you think about how much we prescribe, 10 days of 50 milligrams, 500 milligrams. 4 courses of that, that's 2,000 milligrams. All of us have prescribed that to many of our patients. Look at the mortality rate if we do that. And all-cause mortality here. And they weren't just dying from respiratory disease, okay? They were dying from cardiovascular disease, mental illness, presumably suicide. I don't know for sure, but presumably suicide, and endocrine disease. So it's not just respiratory disease. These people are dying from other conditions as well at a higher rate. And this graph kind of shows it visually quite nicely. Initiation point here, monitoring over 20 years. We have no steroids, low dose steroids. This is 500 milligrams or less, right? This is very low dose. But even between 500 and 2,000 milligrams, you see quite a big separation in mortality. And if you're receiving over 2,000 milligrams, this is pretty dramatic. Now, we don't know for sure. Maybe the patients that were getting high-dose steroids had higher risk of heart disease or psychiatric disease or endocrine disease. I kind of doubt it. So we don't know if it's cause and effect, but there's certainly a strong relationship. And I think most of us would say that there is some effect of the steroids increasing mortality. So the point of this is to try to control asthma so that we do not need oral steroids. And if you're, sorry. In my opinion, if you're going to give oral steroids, you don't have to give heroic doses all the time. So if a patient seems to respond to 25 milligrams for asthma or nasal polyps, then just give them 25 milligrams for 5 days or a week or 14 days. You don't have to give them 40, 50. If they historically need 40 or 50, I mean, obviously we have to prescribe it, but try to minimize the dose if you can. Now, the next 2 topics, I think, are ones that we really don't think about a lot with asthma. The first one is marijuana, and the second one is exercise. We just don't talk about this enough with our patients. So marijuana, of course, has become legalized in Canada, and we didn't really think about the fallout of this. And asthma may be one fallout. In the US, they've studied it now. So in this study, what they looked at were the states that have no legalization at all, healthcare legalization, and recreational legalization, and likelihood of having asthma. So this is the way the states were identified. So RML is recreational. So the dark green states have recreational marijuana legalized like we do here. And then medical legalization are the lighter green colors. And then the gray colors are no legalization. So you can see how things look here in the States. And this is the prevalence of asthma. So recreational legalization is the color to look out for, the blue color. So this is what happened with the states as they legalized. So the outcomes at 2018-19 are post-legalization. And you can see that in the states where it was legalized recreationally, there was a trend down. And if you look at all of the states, and certainly look at the gray color, which are the red states, essentially, in the red states, they're actually having a decrease in the likelihood of asthma. In the more blue states, where we have marijuana legalized, asthma's become more prevalent. If you look at it by age, the age that has been impacted the most are the teenagers. And presumably they're smoking more marijuana. And you can see this hockey stick going in the wrong direction with asthma, where we've seen this 10% prevalence pop up to 12%. And we're talking about all of the United States, states like California and New York, where this is going to be a big issue, where you have 2% more patients as teenagers with asthma diagnosed. If you look at males and females, females seem to be a little bit more affected than males, but you can see that that there is certainly a trend. And then if you look at the different ethnic or race backgrounds, that there seems to be a difference in Hispanics, where it's taken off if you are in a marijuana state, and if you're a non-Hispanic Black, the impact seems to be bigger. So there may be some ethnic racial differences as well. So the next study, published by the same lead author, they actually tried to look at marijuana use and how much patients were using and the likelihood of having asthma. So essentially, sorry for, again, for the busy slide, but if patients have used marijuana in the last month, they wanted to see if the patients that had used marijuana recently were more likely to have asthma or not. And essentially, for all of the age groups, patients that were smoking marijuana recently were at a significantly higher likelihood, 1.7% fold risk if you're a teenager of having asthma. So smoking marijuana seems to be a risk. And again, sorry for the busyness of the slides, but if you look at odds ratios here, smoking marijuana in the past 30 days, 1.4% risk. And the amazing thing here is look at if you smoke none, very little, a little bit more, a lot, there's a dose response as well. So again, smoking more marijuana makes it more likely that you're going to have asthma. And if you're what they call a blunt smoker of marijuana, so basically smoking and inhaling it directly into your lungs, if you use it 20 to 30 days per month, you're 2.2 more likely to have that in terms of odds ratio if you're smoking a lot of marijuana directly. So marijuana has an impact. We don't have Canadian data, but presumably it would be similar here. And then the next topic I want to talk about, and I will admit, I almost never talk about exercise with our patients with asthma. I suspect you as family doctors do this more. We should. And so this is a meta-analysis. So there have been a number of studies published on aerobic exercise and its impact on asthma. And we'll look at this. And then I'm going to show you a study that was published recently on high-intensity training, just 6 months of high-intensity training and its impact on asthma. So this is a typical meta-analysis where they start with over 1,000 papers, and ultimately they end up with 11 quality papers where they did randomized controlled research looking at cardiovascular exercise, aerobic exercise versus standard of care. And very interestingly, if you look at the impact of exercise, in terms of impact on asthma symptoms, you can see that it has a really, really nice improvement. And this is significant in that it doesn't touch the 0 point. So exercise has an impact on asthma control. Exercise has an impact amazingly on lung function. So objectively, we see patients have improved lung function if you perform aerobic exercise. It did not have an anti-inflammatory effect. So they looked at mostly exhaled nitric oxide, but sometimes sputum samples as well. So even though it didn't have an effect on inflammation, it did have an effect on asthma control and on FEV1, which is pretty impressive. And then this group then thought, well, if aerobic exercise is good, why don't we go with HIIT, with high intensity? So essentially they had a 10-minute warm-up. So this was supervised exercise 3 times per week for 6 months. So a 10-minute warm-up and then a 30-minute workout 3 times per week. And they had to get the heart rate up to 90% maximum. What they wanted to do was see how many people they can get from being on high-dose inhalers with high-dose steroids and see if they could taper down their inhaled steroid dose based on whether or not they were exercising with high-intensity training. And so this is how they did the study. 150 patients were randomized, 2/3 to high-intensity training and 1/3 to standard of care, which was not exercising, at least not supervised exercising. So at the end, they had 102 in the exercise group and 48 in the non-exercise group. And this is just to show you that these patients were about 50 years of age. 2/3 of them were females. And they had pretty normal FEV1 at about 92%. And many of them were not in great shape when they started. But these are very, very typical asthma patients that we have in our practices. And this is what they found. If you have patients do high-intensity training for 6 months, then their inhaled steroid dose can come down quite dramatically versus not exercising. So exercise actually has an impact on asthma in a randomized controlled trial. This is looking at, so blue is exercise, orange is no exercise. And if you were in the blue group, then you're more likely to go down in steroid dose. So if you were in the exercise group, you're much more likely, 16% versus 6%, to go down 3 steps in that severity of asthma based on dosing of inhaled steroid. Does that make sense? So, so many more patients improved if you're exercising versus non-exercising in terms of how much better your asthma was. And then they looked at the patients that responded the best. So if you look at the bar that is right of the 0 line, then you'll see the populations where the improvement was the biggest. So if you're obese and you got on an exercise program, impact was definitely big. If you're an overweight female, then the impact was big. If your asthma was poorly controlled at the start of the study, exercise had a bigger impact. And look at this, oral steroids. If you're on oral steroids at the start of the study, then exercise had a bigger impact. And again, I don't think we talk about this enough, and me almost at all with patients. And I'm going to start discussing exercise and asking everybody about marijuana use. I've had a number of severe asthmatics smoking pot that I've seen over the last few months. And now that we have hard data to support this, I think we should be asking them up front if they're smoking marijuana. Again, in family practice, I think you're much better than we are as specialists. Okay, so to close, we're going to talk about allergic rhinitis as springtime has hit. Amazingly, in Southern Ontario, our tree pollen season starts way before our trees start pollinating. We actually get wind-blown pollen from the Midwest US way before our trees are out. So our trees are not really pollinating, but some of our pollen counts, like maple counts, have been high for like a month. So many of us have been suffering already. So now we have a new nasal steroid spray that is now available to us to prescribe, as they had like about a 4 to 6 month hiatus last year because they underestimated production and demand. So these are how we recommend in Canada how to approach allergic rhinitis. So teach patients about avoiding the allergen, prescribe a non-sedating antihistamine, prescribe a nasal steroid, consider a combination nasal steroid spray, consider Montelukast, and then allergen immunotherapy. So this is basically how we've approached allergic rhinitis in Canada for the last 15, 20 years. So we're going to focus on this new combination nasal spray that we have available now. So we've had Dymista available for about, I think, probably 6 or 7 years, maybe longer even. Dymista has inhaled steroid, fluticasone or Flonase basically, and azolastine as an antihistamine as a fixed combination. And it's been 2 sprays in each nostril once a day. And this medication is quite effective. There's 2 drawbacks with this drug. One is that a lot of people complain about this bitter taste in the back of the throat. And if you've tried it, you've probably experienced it. And then the cost is about, it's over $100 a bottle. I don't know exactly how much, but the cost is relatively high. And it's not covered by many drug plans in terms of government drug plans. Most private plans will cover it. The medication works very well. So compared to nasal steroid or antihistamine alone or placebo, the combination medication works better. So whether it's spring or autumn or spring and summer season. So the combination of antihistamine nasal steroid together is good. And this is kind of good because it's been really tough to prove that adding an oral antihistamine to a nasal steroid added much benefit. But if you spray the antihistamine right in the nose, then it probably does help based on this data. And then the new one that's available is mometasone, which is the Nasonex steroid, and olopatadine, which is the Patanol or Pataday eye drop. And in combination, it's called Ryaltris. And this one has a lower dose of steroid, 25 micrograms. So it's 2 sprays in each nostril, twice a day for an adolescent adult. And for a child 6 to 12, it's 1 spray in each nostril twice a day. So the benefit of this is you'll see that it works, of course, but it's cheaper. It's about $60 a bottle, which is cheaper than a nasal steroid plus an oral antihistamine. And it doesn't as much have that taste. I don't get the taste when I use this one, and most people don't get that bitter taste. So it has those benefits. And again, if you look at the combination of mometasone and olopatadine together compared to the steroid and antihistamine separate, that the combination nasal spray, antihistamine steroid together, is more effective than using the drug separately. And another important point is that olopatadine, as you may know, is a mast cell stabilizer antihistamine, but it also has some anti-cytokine effects and anti-IL-5 effects. So it may have an effect on eosinophils as well. And then this is just, in Texas, they have a cedar season. And if you look at the tree pollen season, that the combination is better than using the 2 separate drugs alone. So this is looking at ocular symptoms as well. The ocular symptoms seem to improve if you use both drugs together, mixed together, compared to the nasal steroid alone. So, so we've been using a lot of that medication, and again, it's available now in terms of prescribing, and it may be cost-effective versus taking a nasal steroid plus oral antihistamine. So the last section I want to talk about, when I saw this paper published about 2 or 3 months ago in the New England Journal of Medicine, it was a bit of a shocker because when you actually go through it, it really suggests that in medicine, we have a potential hope for a strong cure for these diseases that we deal with. And this is going to be obviously outside of just hereditary angioedema. So essentially in family practice, if you see a patient with angioedema, especially with angioedema alone, so swelling of the lips or ears or hands without hives, then you treat that differently than if you have angioedema plus hives together. So the first thing to do if you have a patient with angioedema alone is ask them if they're on an ACE inhibitor. If they're on an ACE inhibitor, even if they've been on it for 15 years, stop the ACE inhibitor. About 1 in 200 patients on ACE inhibitors will have angioedema, And when you stop it, then the angioedema will go away. You can use an ARB to replace the ACE inhibitor. The risk of ARBs doesn't seem to be as high. Ask for a family history of angioedema, because this condition, hereditary angioedema, is an autosomal dominant condition, and of course will be passed down in 50%. If you're concerned about these patients, I would refer them urgently to one of us, and even a phone call to us to try to get them in immediately. I have given a bradykinin inhibitor. Bradykinin is the main molecule at the end that causes angioedema. I have given a bradykinin inhibitor a few times that have had ACE-induced angioedema. So there's a drug called FRCPC that works for this. So if you have someone in the unit, ICU or an emerge, you can suggest that they try to get that drug. Epinephrine, you can prescribe if you're worried about anaphylaxis, but it usually does not work well for angioedema on its own. But it does work well if it's associated with anaphylaxis. So hereditary angioedema is rare in that it affects 1 in 50,000 people. It's caused by a deficiency or dysfunction of C1 inhibitor. So essentially, when you have this molecule, C1 inhibitor, the protein, low in the serum, then your inflammatory cascade it goes unchecked, and bradykinin is released. And bradykinin, through a molecule called kallikrein, bradykinin causes angioedema, very similar to what causes ACE-induced cough, right? Bradykinin mediated. And this disease may be life-threatening because it can lead to airway closing. And there are now several new therapies available for this rare condition. And I'm going to talk very briefly about a cure for this condition, potentially. It's pretty amazing. So the way we treat hereditary angioedema is we give on-demand treatment, which is essentially this drug FRCPC, the bradykinin inhibitor, or we can give a blood product, C1 inhibitor, to replace it. There's also short-term prophylaxis, which is usually when someone's going in for surgery, having a dental procedure. Then we would have them receive C1 inhibitor right before the procedure to try to prevent life-threatening angioedema. And then with long-term treatment, there are now 3 very good drugs, 1 oral now and 2 sub-Q that we can give to treat hereditary angioedema. So either blocking kallikrein or replacing the C1 inhibitor that's deficient. And these are the drugs that we have available. Orladeyo or berotralstat is an oral kallikrein inhibitor. Lanadelumab is a monoclonal antibody that's a kallikrein inhibitor. And then C1 inhibitor is literally a blood product that literally replaces what these patients are missing. But lanadelumab and berotralstat block the effect of kallikrein. So kallikrein kind of drives the production of bradykinin. So what this group did was they used CRISPR technology to edit the kallikrein gene, to decrease production of kallikrein. So it's not even going at the primary problem. It's actually going at a molecule that is secondary, but causing that bradykinin production, right? And they use CRISPR technology. The simplest way to think about CRISPR technology is like editing a Word document. So if you know that you've spelled pickle wrong in your Word document, you search for that term, say P-I-C-K-E-L, you made a mistake, you spelled it wrong. You search for pickle, right? And you take that out and you put it in with the right spelling, P-I-C-K-L-E, right? That's kind of the way that CRISPR works. And CRISPR has been used or looked at in many different disease areas. So what they did was that they essentially used CRISPR to impair the kallikrein gene so that these patients were now making less kallikrein, so that there was less bradykinin production and improvement in their hereditary angioedema. This is the... So this is the amazing thing that happened. So they did a dose finding study, 25 milligrams of the CRISPR treatment, 50 milligrams, 75 milligrams of the CRISPR treatment, right? And in a dose response, these patients with hereditary angioedema were producing less kallikrein. Amazing? Great. Look at their disease. So they give the CRISPR treatment here, okay, at week 16 here, and then these are times that these patients were getting their maintenance drugs withdrawn. Each of these bars are a severe or a mild episode of angioedema, so symptoms, okay? After 16 weeks, there were no symptoms that are happening to these people, and all of these patients were withdrawn from their maintenance therapy. So this literally may be a cure for this condition. And if you think about all of the things we deal with, potentially even asthma, if we take out, let's say we modify, well, we're using a monoclonal antibody to block IL-5, right? Or IL-5, we use anti-IL-5 to block eosinophil production. What if we produced CRISPR technology, and I'm sure people are working on this, to impair the IL-5 gene, right? Maybe you just give one CRISPR treatment. You don't have to give anti-IL-5 for 30 years or 50 years. Forget taking out IL-4 and IL-13 with Dupixent for $40,000, $50,000, $60,000 a year. Give one CRISPR treatment, and you get rid of IL-4 and 13, right? And with some of the other diseases where it's even more focused genetically, then you can potentially really have a cure. So the estimated cost of this is going to be probably millions of dollars per patient, but you will have a cure, which is unbelievable. So again, when I saw this, my jaw dropped. When you look at graphs like this, and maybe when we see more patients, there's going to be some fallback, and there's going to, maybe another treatment will have to be given. But certainly, it looks like almost a cure in this group. So to close, there's subtle but important differences in the asthma guidelines. I think we have to have more respect for oral steroids. And again, obviously not just in asthma, but in all of the inflammatory conditions we prescribe it for. We have to start, and I'm guilty of this, in my questionnaire that I send out to all of my patients, I'm going to ask them now, not only if they smoke, but smoke pot, marijuana, because it may be why their asthma is in trouble. I'm also going to now start asking about exercise. And certainly the higher risk people, I'm going to recommend that they do at least high intensity training 3 times per week for 30 to 40 minutes will have an impact on asthma. The medications that we have available for allergy continue to improve amazingly, but we have this new reasonably cost-effective treatment available. And in all areas of medicine, this CRISPR technology that we're copying from bacteria, amazingly, this CRISPR technology may lead to some true cures in medicine. It's truly mind-boggling. I mean, it's amazing. So I think we're going to be in for an exciting time over the next 5 to 10 years of seeing more and more studies like this. And many of our patients with unbelievable disease may actually be cured. We may not even just have to be kind of managing them with our finger in the dike, but actually getting rid of their disease. So with that, Art, I'd be glad to take any questions.
Thank you very much, Harold. Certainly a very practical, excellent presentation, and allows us to implement therapies tomorrow when we go to our office, but also allows us to think of the future and gives us a glimpse of what the future holds for many disease entities. If there are any questions in the room, then we'll start here, and then we'll go on to our online audience's questions.
Your comment on immunotherapy, allergy shots for allergic rhinitis.
Yes, so absolutely. So immunotherapy for allergic rhinitis has been around for 110 years now. And traditionally, we've thought about allergy shots, injections for treatment, which is often the treatment that we still use. And so we have that available for all of the common allergens: ragweed, grass, trees, dust mite, cats, dogs, molds. We now have 5 different treatments for 4 different allergens for grass, birch, ragweed, and dust mite. with sublingual tablets that you put under your tongue, obviously. And so for those ones, we give first dose in clinic, and then they take it at home. It may not be quite as effective as giving injections, but they're safer and quite good. So immunotherapy has expanded quite nicely over the last 5 or 6 years. So
Okay, thank you.
I would recommend that we still consider that in patients where medical therapy is not effective, or patients that don't want to take nasal steroids forever, then I think immunotherapy is still a great option.
Thank you.
Thank you. Just in a follow-up, what are the main risks of that first dose of sublingual immunotherapy?
So rarely, and I've had, I think, 3 cases now out of, I don't know how many hundreds we've given, 3 cases of systemic reactions. So we give the first dose in the clinic, and we usually have them wait for half an hour. About 40 to 50% of patients will have local oral, ear, tongue side effects that usually go away in the first 5 to 7 days. So we treat that with antihistamines. And then long-term, there's a potential risk of getting allergy of the esophagus, EOE, eosinophilic esophagitis. If you're swallowing some of that allergen down through to your stomach, then you may be causing eosinophilic inflammation. So those are the main things. But in the office, it's a small risk of anaphylaxis.
Okay, thank you. You are making us all think about marijuana consumption, and particularly smoking marijuana. Is it the combustion that's the issue, or is it the actual agent? And would vaping be an alternative that we could at least recommend to or support our patients in their need to consume marijuana?
So I don't think we know yet if it's a component of the specific component of the marijuana, or if it's just the smoke, period. My suspicion is it's a combination of both. I've now had a number of patients that get worse when they're smoking marijuana with regards to asthma, and we skin test them with the marijuana, and their skin tests positive, so they're actually allergic to the marijuana. So that's probably happening more often than we think. But I think it's a combination of both. Vaping in medicine generally, I think even with vaping, we're trying to discourage it in that it may lead to other problems potentially with regards to infections, et cetera, that have happened. It may be better to vape than to smoke, and it may be better to eat it than to smoke it. But in my experience, when I've tried to get patients to stop smoking, it's almost never successful, because they are just, I don't know if they're truly addicted or not, but they're truly, requiring inhaling it as opposed to swallowing it. So, but I think swallowing probably would be safer. I'm assuming, unless there's some unknown gut effects that we're not aware of. Oh, hi.
Thank you, Dr.
Thank you.
Kim. I have a pretty specific question, this one. After stepping up the patient because they have a moderate to persistent asthma, mostly due to the work-related asthma, but the patient cannot afford the puffers, so continue to use the short-acting Ventolin. How do you address this issue?
That's a great question. So in 1990, Malcolm Sears, who was in New Zealand at the time and subsequently immigrated to Canada to McMaster, identified why so many of our patients were dying from asthma in the late 80s. And it was because they were taking bronchodilator alone without inhaled steroid. And then in the mid to late 90s, there was a study, ironically called the SMART study, where they did a study looking at salmeterol, which is the bronchodilator in Advair, on its own without inhaled steroid, and there was a mortality signal. So if the patient's on bronchodilator alone, then they're probably at a higher risk of having more severe asthma, possibly even a higher risk of mortality. There is an increased risk of mortality. So I think the simplest thing is actually to prescribe the combination inhaler Symbicort with steroid bronchodilator together. It's not cheap in terms of if they have to pay out of pocket. So I think encourage them to log into Trillium in Ontario and get Trillium coverage if they can. I have always had a hard time finding through navigating through the websites to get to Trillium. I was finally successful actually this week. It's tricky. But after 3 or 4 steps, you actually get onto the Trillium site and you can apply. And I think if you have a low income, then I don't think you're going to have to pay a lot or anything to get free drug. So that's what I'd recommend. And then Symbicort is indicated or is covered by ODB and Trillium, I think, if you get coverage. But I'd recommend both together, unless you can convince them to take the steroid salbutamol together. So fluticasone or budesonide or Alvasco, Qvar with salbutamol together. I think that makes it safer. But I think Trillium's the solution if they can't afford the steroid or the combination inhaler.
Thank you. Actually, this fits in with the next question. Which steroid do you use in combination with a bronchodilator if you can't convince them to take a combined therapy?
Great question. So I think any inhaled steroid with the bronchodilator is fine to take. And even if you're using more than 4 inhalations per day, which is kind of the standard dosing, taking an extra puff or 2 of steroid with the bronchodilator is not going to be harmful short term. So I would say any of the ones that I listed, Alvasco, Qvar, budesonide, Flovent, fluticasone, all of those are reasonable steroids to use with the bronchodilator.
Okay. This question has to do with Alvasco, and our colleague comments that it's a smaller particle than other ICSs. Would this make it preferred as an inhaled corticosteroid?
Great question. So Alvasco and Qvar, the brand names, and Qvar's beclomethasone, Alvasco's ciclesonide, have small particles. So they do get, when you look at marker studies where they mark the drug and see where it goes in the lungs, it does get out to the smaller airways. It's been difficult to absolutely prove that taking one of those compared to taking one of the other steroids leads to any clinical difference. But it does have that potential advantage, but difficult to prove clinically that the small particles actually make a difference clinically.
Okay, thank you. We have a number of questions on the risk associated with oral steroids. And this question is the lifetime risk of oral steroid use given at an early age more than 2 grams the same as given small doses repeatedly over a prolonged period?
That's a great question. And so we don't have an answer to that. We only have data in adults. So it's very possible that getting steroids when a person's under 18 would have that persisting impact on mortality long term. My suspicion is it's probably going to have some impact on mortality, but it hasn't been looked at yet.
Okay, thank you. We have a number of questions on nasal steroids, and this question has to do with intranasal steroid treatment. Does it affect ocular symptoms?
Question. So if you take a nasal steroid, probably any nasal steroid, it does improve ocular symptoms. And it's actually better than taking an antihistamine. Oral antihistamine is not as good as a nasal steroid. If you're going to treat ocular symptoms, though, the best way to treat ocular symptoms is with one of the dual agent eye drops, which are the main ones are Bepreve or the Pataday, olopatadine, Patanol eye drops. So both of those are the way to go if the eye symptoms are severe. But if you have mild eye symptoms, then a nasal steroid may be enough to treat them if they have rhinitis and conjunctivitis. Now, on the flip side, there may be some side effects. You saw the OCS side effects on cataracts. There was a meta-analysis recently suggesting that nasal steroids do not impact ocular pressures. I think it does impact ocular pressures in some people. So if you have a patient on long-term nasal steroids or even inhaled steroids, orally inhaled for asthma, then I think they should be seen by their optometrist every 2 or 3 years to make sure that there's no impact in terms of ocular side effects.
Thank you. How long does one stay on intranasal or nasal steroids when you've achieved control?
Sorry, how long?
After they've achieved control, how long do you continue them?
Yeah, great question. So we do not have an answer to how long they should stay on it. What I recommend, because allergic rhinitis is not a life-threatening problem, and it's more of a quality of life symptom problem, I usually say use it regularly when needed. So taking it for a month after the symptoms are gone, I think is reasonable. And then if the symptoms come back, if there's a pattern and they come back in a month, then I think it's reasonable to stay on them. And those would be the patients where I'd recommend thinking about referring for immunotherapy, where you really have a disease modifying effect. If they need the steroids kind of indefinitely, I think it's reasonable to refer at that point.
Thank you. Are there cultural differences as it relates to allergic rhinitis symptoms,
Cultural differences. Ooh.
both in terms of presentation and management strategies?
So the cultural differences in terms of presentation, I actually don't know. I'd have to look back and look at the randomized controlled trials and see if Asian patients are different than Caucasian patients, et cetera. So I don't know that. But treatment-wise, generally, if you look at, and I don't know about say East Asians in Canada, but if you look at, say, the Japanese population, for example, apparently they're much more likely to take tablets as opposed to inhaled or sprays in terms of products. So there may be some cultural differences in terms of what patients prefer. I think in many patients, and some of it's cultural, that some people prefer needles as a more effective treatment than taking something orally or inhaled. So those are potential issues. But I think, yeah, culturally, I don't know about symptom presentation in terms of if there's differences.
Thank you. Getting back to the use of oral steroids, is it the cumulative dose over time, or is it the fact that you give large amounts or short bursts of large amounts?
Great question. So the answer I don't think is known yet. In that study, they just looked at total dose, and it's possible that, you know, a patient getting 50 milligrams a day, a month straight, may have died from pneumocystis, right? As opposed to somebody getting 5 milligrams for a year. So absolutely, it's possible that very high doses over a medium term might be riskier than being on 5 milligrams over a year. But in that study, they basically looked at cumulative dose. So I don't think they were able to tease out how often it was high dose for short term or low dose for long term. My personal feeling is I think probably either way of receiving it's going to have an impact on morbidity and mortality.
Okay, thank you. Please comment on black mold in asthma.
I just had a patient today with Aspergillus allergy. I think one of the biggest impacts of global warming in terms of healthcare is going to be mold in terms of respiratory disease. And the reason for that is the shorter our winters are, the more mold exposure we're going to get in terms of inhaling it. And one area is allergic bronchopulmonary aspergillosis, which is basically an immune reaction to Aspergillus black mold in the lung. And I think we're going to be seeing more of that. But certainly in patients with severe asthma, mold exposure and mold allergy is a common cause of really terrible disease. And if you look at allergens generally, the most common allergens that cause asthma are pets, molds, and dust mite. So molds have been linked with severe life-threatening asthma attacks in the US. When mold season's high, then you're more likely to have severe asthma. So mold is a major issue.
Thank you. When asthma is controlled on inhaled combination therapy, ICS and bronchodilator, at what point do you consider reducing the dose, and how do you decide what is the lowest effective dose?
Great question. So I think we use a mix of criteria. So it would be symptom control. So no salbutamol requirements or other extra rescue requirements, no night symptoms, no exercise limitation. I would recommend thinking about having spirometry done and checking FEV1 and making sure they're within 10% of their personal best, and they've had no exacerbations. And then I would step down. And I would step down to as little as you need, whether it's usually at least 1 puff a day, but between 1 and 4 inhalations per day I would use. And then if you can get that low, then you can go down to an inhaled steroid or even combination PRN. But I would say if they're controlled and their breathing levels are normal.
And how often would you do spirometry?
I think if patients are stable once per year, but certainly if they're having changes in treatment or if they're not controlled, then I would try to get it done more frequently. And I appreciate it's easier said than done to get spirometry on a frequent basis. If you're in a large group practice and family practice, something to consider is actually getting a spirometer and having maybe a respiratory. Some larger clinics have asthma educators come in, but you can have your nursing staff or admin staff to learn how to do spirometry testing, and it's actually quite useful. So if you're in a large enough group, it can actually be cost effective, and as long as people are trained to do it properly.
Okay, thank you. And would these comments apply to the pediatric population as well as the adult population?
Absolutely. So if a child is over 6, then they can usually do a reasonable spirometry. And we try. I mean, they're not perfect, but we often get a good result. At least you can usually get a good FEV1. The FVC, which is the amount that we measure with the full expiration, is tougher to get in kids. But the FEV1 is often very good after age 6.
Okay, thank you. When it comes to asthma, we all have patients who are not always good perceivers of the extent of their disease. Any tips in terms of clinical assessment that might give us guidance in picking these individuals out?
Yeah, the poor perceivers are tough. So I think you have to ask the specific questions about asthma control, like we've discussed, nighttime, salbutamol, exercise limitation. Try to get an accurate measure of how much rescue inhaler they're using. Sometimes even calling the pharmacy up to see, because sometimes they don't even appreciate how much they're using. And then if you can do spirometry testing, and if you have access to exhaled nitric oxide testing, which most of us don't have, but it's an inflammatory test that we can measure in our clinic. And then if that level is high, then it suggests that they're probably not taking their inhaled steroids regularly. But the poor perceivers are tough because they can go downhill fast without appreciating it.
Thank you. How does Brio compare with Symbicort?
So Brio is a good drug with a combination steroid long-acting bronchodilator, but officially it's not allowed to be used as a rescue inhaler because the bronchodilator doesn't respond as rapidly, and it hasn't been really studied well as a rescue inhaler. So the Symbicort has the advantage of rescue. The Brio is once a day, kind of consistent dosing. So some people would say that if you take Brio regularly and it controls things, and that's fine as well. But the advantage of Symbicort is that maintenance and as needed, as it being formally indicated in Canada.
Okay, thank you. And when do you decide to add Olama?
So if a patient's on a combination inhaler, Brio, Symbicort, Advair, any of those, and they're not well controlled, or if their FEV1 is lower than it should be, then I would add Olama. And we're actually reviewing this now. And the drug that really has been best studied as Olama added on to a combination is Spiriva. Aside from using Spiriva, probably the best approach is to go with a triple inhaler for like Trelegy or Enerzair as a maintenance inhaler if you're going to adding Olama. So you either go combo plus Spiriva or go to a triple therapy inhaler.
Thank you. You talked about spirometry. Is there a role for the use of peak flow meters?
So peak flow meters used to be so popular in the 80s and 90s. The problem with peak flows is that it's really user dependent. And in occupational asthma, for example, is one area where I think peak flows could still be useful. But even there, if the operator is not using it properly, then it's not reliable, as opposed to doing a spirometry where we can actually get a very good idea that they're doing it properly. But a peak flow, I think, for poor perceivers actually is a good time to use that. So if you have patients that are poor perceivers, they have occupational asthma, you're trying to investigate, then we often do use peak flow. But it's kind of fallen out of favor because there were some studies suggesting that just asking about asthma control was as good or better than doing peak flows. So just asking the 5 or 6 questions for asthma control is probably is good for most asthmatics.
Thank you. And as I recall, peak flow meters are not inexpensive.
No, I don't know how much they cost, but they're probably at least 60 or 70 bucks, I would think. So
Thank you. Is there a preferred steroid, both in terms of inhaled and oral in the pediatric population,
yes, so in
and
terms of,
particularly under 6?
yeah, in terms of inhaled steroids, I think that Alvesco probably is the safest steroid for anybody, but for under 6 as well. The only drawback with Alvesco is that it's a prodrug. So if the patient doesn't have the enzymes available to activate it, which potentially may happen, then it may not be as potent. So drugs like fluticasone or Flovent, Qvar, Alvesco would be the ones to use. I usually try Alvesco first, then go to the others if it's not effective. In terms of oral steroids, certainly there is a preference in most pediatric emergency departments to give 1 burst of dexamethasone for many different conditions, and I think even in asthma and croup as well. I don't know if there's any good head-to-head data to say that one oral steroid's better or worse than another. I think that all of them have the potential to improve and, of course, to have side effects as well. But I would encourage shorter courses of oral prednisone, as I've said, even with asthma. If you can get away with 5 days or 7 days as opposed to 14 days or longer, I'd recommend it.
In terms of our discussion around oral steroids or prednisone, there seems to be a tendency to go to 50 milligrams 1 a day for 5 days rather than create a titration schedule for patients. But based on your discussion, one should consider perhaps a lower dose. How do you know where to start?
So I don't think we ever know for sure where to start, but if you, and you would in family practice know how well, if a patient responds really well to 50 one time, maybe try them on 25 the next time. And of course they can up dose if they have to. But I would say if you can get away with 25 milligrams for 5 days or a week, instead of the longer courses, then I would encourage it. We've traditionally used 50 because it's 1 pill, and it's kind of easier to take as opposed to taking 5 little pills potentially. But I would lean toward the 5 little pills or half of a big pill if you can get away with it. And of course, if they need 50, they need 50. But if you can get away with 25, I'd recommend it. For the polyp patients, they often respond to lower doses of steroid. And it's not a life-threatening condition. So if it's nasal polyps that you're treating, then definitely try to get away with 20 or 25 milligrams for a short course instead of longer courses and higher doses.
Thank you. Are nasal steroids relatively contraindicated in patients with glaucoma?
Ooh, so I would say, in my opinion, they should be. I don't think they're officially contraindicated. If patients, so I try not to use nasal steroids in patients with glaucoma. If I have to use them, then I ask them to be monitored very closely by their eye physicians, often an optometrist that can measure pressures and examine the eye properly. So I don't think it's officially a contraindication or even a relative contraindication, but I really do try to stay away from it if I can.
Okay. Thank you. We've spent a fair amount of time talking about oral steroids in the management of acute asthma. Please discuss the whole step-by-step treatment of acute asthma.
Of acute asthma.
Yes.
Okay. So what I would recommend is to use the combination of steroid and inhaled steroid and inhaled bronchodilator. And if that doesn't work after a few doses, 2 puffs, and then if that doesn't work, 4, and then if that doesn't work, probably the patient should go into the emergency department. In the emergency, especially on the pediatric side, they'll often give Atrovent along with bronchodilator in Emerge, and almost always they'll get systemic steroids. And then, of course, if they're in Emerge and they're having great difficulty, then they would have to involve pediatrics or internal medicine, respirology in terms of getting patients to ICU, intubated, intravenous therapies. But generally, bronchodilator, steroid, and if they need 6 puffs and they're really not getting better, then they should be thinking about going into Emerge to be assessed. So a couple of times with bronchodilator steroid.
Thank you. And you already introduced or touched on Atrovent. And in terms of the non-acute episode, where does that fit into therapy?
So Atrovent has not been a drug that we've used as maintenance therapy. And I think generally because if you're going to add a LAMA type drug, then Spiriva with its long-acting effect is better. And certainly on the adolescent adult side, the improvement in exacerbations and FEV1 is better with Spiriva. I don't think it's been shown to be nearly as good to use Atrovent. But in an acute situation or as a rescue inhaler, it's reasonable to add it on, especially in kids. But we don't even often have to do that.
Okay, thank you. You just went through the steps in terms of acute asthma. Please review the step-by-step therapy for general asthma management. You had your 5 steps, and if you could just review that once more.
So the first thing is to make sure they're exercising and not smoking too much pot. And then after that, so obviously all asthmatics should have a rescue inhaler. And as I've said, I think it should be a steroid and bronchodilator together. And then if they need more than that, they can either go on, if they're mild, inhaled steroid alone, and then combination after that, high dose combination, consider adding the LAMA, and then going to biologics. Possibly also adding azithromycin 3 times per week. There's a couple of studies suggesting in adults that if you add azithromycin, it might help asthma. And then if you have more moderate asthma, then they would have the combination inhaler as a rescue, and then low dose combination as first maintenance step, medium dose combination, and then getting into the LAMA, triple therapy, and biologics.
Okay, thank you. Please comment on the relationship between allergic rhinitis and asthma, and allergic rhinitis being a trigger for asthma.
Yeah, so in the late 90s and early 2000s, we really tried to get across the idea of the one airway concept. And I think it's actually still true. And there's data from way back suggesting that if you treat the nose with a nasal steroid, the lungs get better. If you treat the lungs with an inhaled steroid, the nose gets better. And that's with actual biopsy studies. So it actually does work. So there is a unified response. And we encourage and that everyone asks about nasal symptoms with asthma patients and lung symptoms with nasal patients because they often coexist. So 80% of asthmatics will have rhinitis, and probably 30% of rhinitis patients will have asthma. So they're strongly linked. And then you can also throw in eosinophilic esophagitis, atopic dermatitis, and food allergy in the mix. And often the patients have any combination of those conditions, but certainly the nose and the lungs are strongly linked.
Thank you. There is a combination of omeprazole and formoterol. Can it be used in both for ongoing treatment and rescue?
So yes, so that is Zenhale with mometasone and formoterol. So in Canada, it's officially not indicated as a rescue inhaler. I think it can be used as a rescue, but I typically, if a patient really wants an MDI as a maintenance and rescue, I would max out that at 6 puffs a day of the Zenhale. But officially, it's not indicated as a rescue inhaler in Canada. So, but it should work. My concern is patients that are on high dose of the steroid component, the mometasone. It's more lipophilic than budesonide, and certainly we've seen in kids that are on high dose mometasone inhaler with adrenal suppression. So even in adults, we've seen a number of adults with adrenal suppression. Actually, that was kind of pointed out in the oral steroid study. But many patients with high dose lipophilic steroids will be more likely to have side effects long term. So I try to discourage too much of the Zenhale because of that, more of the steroid effect than the bronchodilator issue.
Thank you. There's more than one SABA, but yet we seem to have only one in Canada. Can you comment on the others?
So the other one that we don't use hardly at all, but it's a good one, is Bricanyl, which is terbutaline in a Turbihaler. and then salbutamol. So those would be the two SABAs alone. There are SABA-LABA, like formoterol on its own, or oxys. I think it's still available in Canada. We don't prescribe it very often, but that'll be fast-acting and long-acting. But the only real short-acting bronchodilator other than salbutamol, I think in Canada would be terbutaline or Bricanyl.
And is there a particular reason why salbutamol seems to have 99.9% of our attention?
I think it's kind of like the Coca-Cola of inhalers. When it first came out way back, the branding was amazing by GSK. So they were really successful with branding. And then I think that's just it. And I think just the puffer aspect of the device has kind of been synonymous with asthma, literally. So I think it's been that. I don't think it's any better than taking Bricanyl or terbutaline. I doubt that head to head it's going to be any better, but it's just been kind of the way it's been. It's strange.
Okay, thank you. We have a couple more questions about smoking pot. And one is, does asthma improve when you stop smoking pot?
I haven't had a lot of success, as I pointed out. But if you look at the studies, especially that second marijuana study where there's a strong dose response between a little bit of pot, a little bit more pot, and a lot of pot, there's clearly a dose response to severity of asthma. So I think probably if we can get people off smoking it, that their symptoms are going to get better.
Okay.
I think there's a dose link there.
And although we're focusing on asthma, is there evidence to show that smoking pot increases the likelihood of COPD and perhaps lung cancer?
I don't know. I don't know about COPD and lung cancer, and I suspect it's going to be looked at by the same group at some point soon. So, but I don't know. It may not have been long enough legalized to have the studies done yet.
Okay. For mild exercise-induced asthma, do you recommend using salbutamol inhaler 15 minutes before exercise, considering that the patient is not taking inhaled steroids?
Good question. So yes, absolutely. So I do recommend a bronchodilator 15, 20, 30 minutes before exercise, but typically I recommend both, like the steroid and bronchodilator together now. Obviously, most groups will be recommending the bronchodilator alone. But most patients with exercise-induced asthma have it because they have airway inflammation and then exercise triggering bronchoconstriction. So my personal feeling is to deliver both drugs even in that situation.
Thank you. Based on the fact that it's not always easy to get spirometry or a PFT, and we have a patient that we make the clinical diagnosis of asthma and start them on an ICS-LABA, will that not impact on the testing? And if it will, what do we do? When do we stop? How do we manage that?
So typically what most PFT labs will do is they'll send information to the patient on which drugs to stop before specific testing. So if we're doing reversibility testing, we make sure that the bronchodilator is not taken too soon to the breathing test. If we're doing methylcholine testing, then we'll actually send the patient info on which drugs to stop at what time, because they will have to stop some of the drugs because it may impact testing.
Okay.
So we will educate the patient beforehand.
Okay. And is there still a role for montelukast in the treatment of asthma?
So montelukast does have a role, admittedly diminished. And again, some of that may have to do with marketing. I think truly there is some benefit of marketing a drug like that. It probably did not have a huge, so I don't think it has a big impact adding it onto a combination inhaler. And combination inhalers are better than steroid plus montelukast combined. So I think the combination is probably the way to go for most people. The big exception will be in children. So in children, even between 6 and 12, I think using montelukast is very reasonable. And in younger kids, I think it's a very reasonable option. I just saw one today who is on montelukast alone, a young child, a 3-year-old, and she's doing really well. And she definitely has asthma. So I think in some patients, it's going to be a benefit. And I think in many patients, even where combinations don't seem to be working, I think we don't think about it enough right now. I think it's still something we should consider adding on, even in our severe asthmatics, because sometimes they get better.
Thank you. And just to follow up to that, in patients that have high eosinophil counts, would that be a better indicator of good response?
So with almost all asthma studies that have been done where the eosinophil counts are high, almost every drug seems to work better. So I would say that probably it will work better. But when Montelukast Singular was first released, there was a few cases of Churg-Strauss syndrome. So eosinophils going crazy high. And probably for most of those patients, it happened because they were stopping their oral steroids, going on Montelukast, and then their Churg-Strauss became poorly controlled. But I would say that in most situations, even with high eosinophil counts, you know, up to 1, say, I wouldn't be concerned about any of the drugs that we have available for asthma. They should all be reasonably safe and probably more effective in those patients if they're anti-inflammatory drugs.
Thank you. And this will probably be our last question. In the management of an acute allergic reaction, is there a role still for first generation antihistamines, or should it all be second generation?
So for a systemic allergic reaction, the treatment, if it's severe enough, should be epinephrine. There's actually studies with oral steroids, Canadian study, suggesting that oral steroids used for anaphylaxis might actually increase the risk of problems afterward compared to not receiving oral steroids. And antihistamines have never been shown to be effective for the significant symptoms of a severe allergic reaction. And we generally do not recommend first generation, like Benadryl, diphenhydramine, because it can be sedating and impairing. So typically, and it may cloud our management. So typically, if we're going to use antihistamines, we'd recommend using a non-sedating antihistamine even for acute treatment. And I realize that we don't have any parenteral antihistamines aside from Benadryl IM, and that's one of the problems, I think. Unfortunately, it's probably, you know, kind of not a huge market for these companies to pursue, but it would be really nice if we had non-sedating antihistamines as IM injections. But even then, there's never been any studies to show that IM Benadryl helps for anaphylaxis. So I would say use non-sedating antihistamines or no antihistamines for allergic reactions if you can get away with it.
Okay. And what dose? How high can we go with the second generation?
So say with cetirizine reactine, which would probably be the most common, you go up to 40 milligrams. Blexten, 40 milligrams, so 2 tablets of Blexten. Rupall, which is another prescription one, would be 40 milligrams. So 40 is a good number to remember. Arius would be 20 milligrams. Claritin would be 40 milligrams. So four tablets of the standard dosing, essentially.
Okay. Thank you. And I guess we do have one last question. How do you diagnose asthma in young children, especially those under 6 or others that can't do spirometry?
So it's very difficult to confirm asthma in patients with that can't perform spirometry. So it's a clinical diagnosis. And so obviously there's the classic symptoms. And then if in the young kids, if they're atopic, so food allergy, eczema, and especially if there's a family history and especially a maternal history of allergy and asthma, then it will increase the likelihood that you're treating the right condition. And really, aside from really severe disease, if you're treating with an inhaled steroid bronchodilator, generally you won't be causing harm. And if you're using recommended dosing, then I think that's the way to go. But unfortunately, you have to wait till at least 6 and probably even older to really confirm asthma in many patients with breathing tests.
Thank you. Thank you for your excellent, very practical presentation and addressing all these practical questions. We should be better prepared to manage our patients when we go back to the office tomorrow. For our audience online now, it's time to complete your evaluation, submit it, and you'll receive your certificate of attendance. For those in the Toronto or Humber area, please consider attending the unveiling of Janice Woods Memorial on April 26th. And if you wish information, please email either myself or Streamcast at info. And otherwise, we will see hopefully many of you back on the 1st of May for our hybrid session, and many of you on May 8th to 10th at Pri-Med Canada. So thank you.